Hello, welcome to Unmute Your Probe, a podcast where we discuss current developments and controversies in point-of-care ultrasound. I'm your host, Dr. Melissa Myers. This podcast is through the Emergency Ultrasound section of the American Academy of Emergency Medicine. I do need to put a disclaimer. The opinions and assertions expressed in this podcast are mine and do not reflect the official position or policy of the Uniformed Services University of Health Sciences or Department of Defense. With me today, I have Dr. Jordan Dow. He is the Director of Ultrasound Education at the Northeast Georgia Medical Center. Dr. Dow completed an emergency medicine residency at Kings County SUNY Downstate Health Sciences University and a fellowship in advanced emergency medicine ultrasonography at George Washington University. And today, we are going to talk about dramatic U-turn cases, or times when point-of-care ultrasound dramatically changed the direction of a case. And that sounds fascinating to me. So Jordan, what is a U-turn case?
U-turn case series is something we're trying to introduce to the residents now. And I have to give the credit to Dr. Keith Boniface. He's the chief of ultrasound over at George Washington and introduced a few cases. The first time I remember him talking about it was in a rush case or in a rush lecture. But he mentioned not only did we find the pathology, but there was a dramatic U-turn in the clinical management. So we decided to change what we were doing, or the kind of train that was heading in one direction had to change that direction because of what we found on the ultrasound. And for this case series, though, not every U-turn is going to be something that changed clinical management in a way that we were maybe happy about or that objectively was good for the patient. I think both the article that I shared as well as my own lived experience is that sometimes you take a U-turn and it wasn't necessarily what the patient needed or didn't get you to their definitive diagnosis. And so I think it's a case series that's meant to be subjective and meant to spur discussion.
Yeah, that sounds so interesting to me because I'm like you. Like, I would probably scan every patient in the ER if I had time, but I don't have time. So you have to decide how to determine which patient is the right patient. And speaking of this article you sent me, this article was great. The full title is Point of Care Ultrasound Induced Changes in Management of Unselected Patients in the Emergency Department. And this was done in Denmark, where they have, I thought, really interesting differences in how emergency medicine works. We're going to talk about that in just a second. But if anyone's looking it up, it's in the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine. And it was published by, there's no way I'm pronouncing this correctly, but I'm going to try, Wiley or Reilly in 2020. So Jordan, tell me a little bit about this paper.
Yeah, I used this paper early on in talking to residents and early on in their intern year. And I do say that it's Focus Everybody because it caught my eye initially. It's 35,000 patients. It's Denmark. It's a hospital that sees 35,000 patients a year. A lot of the MI, stroke, labor patients were diverted elsewhere. So admittedly, it is a different environment than the ones that I've trained and taught at. But what more so caught my eye was just that they were trying to see, okay, if we just scanned everybody, all comers, and by scan, I mean, they did a cardiac ultrasound, pulmonary, a fast, and then they did this focused abdominal ultrasound that's mostly gallbladder, aorta, and then a second look at the kidneys, more dedicated to looking for hydro rather than just Morrison's pouch in the left upper quadrant. And it reminded me of how I felt in my own residency. It sounds like maybe you had a similar experience, like the hospitalists or the residents who were running the hospital service would joke and say, wait, you didn't ultrasound this patient on every single patient. And I know for me, I understood that a lot of the attendings, especially the ones who weren't interested in ultrasound, they're trying to help me understand how to prioritize my time better and trying to decide whether this was relevant. And I realized the truth is this is somewhat of a new modality. This is something that us in the ER, we're trying to figure out where its place is. And so I felt pretty comfortable understanding that I was going to go on my own journey of figuring out what a necessary ultrasound was for me. If I ultrasounded too much, that's okay, because I'll pare that down as I move along in my training. And I had a lot of support from Kings County, SUNY Downstate, where there were many ultrasound fellowship trained attendings there. And I had a lot more support there than maybe the average residency. But anyways, the big outcome in the study was that of the 403 patients they selected, 1 in 6, they said, changed management. And when they looked to confirm the diagnosis, they felt comfortable saying, okay, 1 in 10, met that confirmation of diagnosis. And so they came up with this number of 27% of patients benefited from this ultrasound. I just throw those numbers out at the residents and I ask them, hey, if we felt pretty confident in this skill set and you thought that it could change 1 in 6 of your patients' clinical management, would this be a worthwhile skill to develop? Would this be something that you would want to really have a good sense in, okay, what are those 1 out of 6 patients? And make sure you have the skill set to get a good scan on them. That's how I introduced this.
Yeah, it made me think about all the tests that we order every day that definitely don't change management in 1 in 6 patients. I'm thinking of the thousands of CBCs I've ordered over the year and how many times has that really changed anything? 1 in 6 seems like a pretty high percentage.
Yeah, it's pretty high. It's pretty high. I think if you're like a 12-hour, if you're a resident, you're like, okay, I'm working 12 hours and I'm trying to get to a point where I'm seeing 2 patients a shift. Okay, that's 4 patients a day. 1 in 6 patients, 4 patients a day. I think that's probably one of I don't know how many single studies changed the clinical
Mhm.
management in 1 in 6 patients, except maybe a CAT scan, of course.
I should probably note this. So this was in Denmark, so it was a little different than our American emergency departments. The paper noted that they only received patients by referral from general practitioners or by ambulance. They didn't take walk-ins. And MI, stroke, labor, and pediatric patients all were diverted outside their ER. So they did scan all comers, but they didn't probably have the fast track that an American emergency department might have. So they probably skewed just very slightly sicker. But yeah, there were some, I thought, really interesting results in here. I noticed I was not familiar with the triage system that they used. It was very different than the American system, but certainly it seemed that there was a definite correlation between higher triage categories and focus being more likely to change the diagnosis or confirm the diagnosis.
And just anecdotally, I would expect that just because in my experience, the sicker patients typically are the ones who I'm bringing that ultrasound to. I'm maybe thinking a little bit more. I maybe need to bring this to the bedside. Almost all of my undifferentiated hypotension patients, I'm going to bring my ultrasound to the bedside. And those are typically the higher triaged patients. And so I would expect that, but I'm always wondering if there's a resident or a couple residents who want to decide to maybe redo a study similar to this, because I'd be really curious to see what it looks like on our end and maybe with slight tweaks to this.
Definitely. And they found that it was particularly useful in abdominal pain, dyspnea, and syncope. And again, that kind of marries up, I think, with what I've seen. It was making me think about the not as sick appearing patients that I've seen over the years with abdominal pain, particularly where I didn't really know what was going on. So I was like, let's just look at the gallbladder. And it turns out they had gallstones or hydronephrosis or something else where I was diverting from a very benign diagnosis to actually, like, we should probably look into this. So helpful. All right. With that as the background, let's talk about these U-turn cases. Tell me about this. So you said that you guys do a case series. Do you do this with the residents or fellows, or how does that work?
With the residents, we don't have an ultrasound fellowship here. We're a 3-year program. We're graduating our first class this spring, Northeast Georgia Medical.
Congratulations.
We opened 2022 with the emergency medicine residency. It's a big hospital, definitely good pathology. Basically, everything north of Gainesville up to South Carolina, we get those patients. It's a huge catchment area. So the residents came to a good place to learn ultrasound, I feel. But what was different about here is you had a pretty long-standing group of ER docs who were excited to teach residents, but hadn't had a whole lot of experience with that. And so actually listening to Dr. Gutman's lecture that you were speaking with him last episode, he was talking about consulting and going to different residency programs and bringing up these concepts of needing to teach the teacher, and how you asked him, like, what's the difference between academic and community sites? And he was like, the academic sites have these evaluations and you have to teach those teachers because they're the primary way that the residents are going to learn. And that is totally my experience, that even the attendings who use a lot of ultrasound, who are big on ultrasound, they didn't necessarily have the experience of teaching it. And so this U-Turn series brings us all together. It's something that when we do an image review in conference or didactics, this is how we communicate, okay, these are the interesting cases, but not only are they interesting, but they changed clinical management. They caused a potential U-turn in that clinical management. And so that's where that's the intention of the case series. And it's been a lot of fun. For the most part, we source these images from our own, like us who are QAing images. We see something interesting. We go to look at the confirmatory study and we're like, wow, this kind of really changed what was going on. Some of the cases are my cases, but the residents are free to submit if they think that a case changed clinical management. But usually it's such a Monday morning quarterback kind of idea. When you have that patient who gallstones and you weren't expecting it, that's pretty straightforward. But as we'll see in some of these cases, it's not so straightforward whether it changed clinical management. And I do think that's although I'm somebody who loves ultrasound and brings it to the bedside all the time, I also understand that sometimes it is not necessary, and sometimes there are competing priorities in the ED that we're always working with. And so I like the subjectivity of this case series.
Awesome. The last things I know everyone's waiting on the cases, but I wanted to highlight a couple of things that you said y'all look at when you're doing this case series. You wrote that you highlight incidents where looking beyond the protocol and keeping a broad differential when scanning drives quality patient care. And I loved that. And I wanted to make sure that made it into this recording because it's such a great way to look at how we can use POCUS. So let's talk about these cases. They sound fascinating. This first one you wrote, actually, you know what? I'm going to let you introduce it because I don't want to give away the fun part. So tell me about this first case.
Yeah. Would it be helpful to share my screen to kind of look at any of these images, or is it since
Most folks are going to be hearing this in an audio format. So unfortunately, we really can't share the images, but talk us through it.
Of course, these are images I love to share because they're pretty interesting. But so the first case is Dr. Boniface is my chief's case, and this is the case that really inspired me in the first place. It was a patient who was 62 years old, history of end-stage renal disease, was sitting in dialysis, their normal state of health, and became dizzy. The dialysis nurse checked the blood pressure, they were low, sent them to the ER. They arrive in the ER with pretty concerning vital signs, 80/52, heart rate of 110, but they were not hypoxic and afebrile. And I think we get patients like this all the time who come in from dialysis who are hypotensive, and we're trying to figure out, okay, these patients can have some significant pathology, but we also just drew a lot of blood out of the body and shoving it back in. I would expect some level of hypotension somewhere in that process. The patient immediately had a rush exam, which is not always performed, but Dr. Boniface is amazing, and he's a great teacher and clinician. And started out with the heart, and you can see a pretty significant effusion. And what I like about this study, and the part of the reason I like to show this image, is we've all had the experience of teaching the difference between a pericardial and a pleural effusion and peristernal long axis. You have sometimes fluid outside of the left ventricle that you're asking yourself, okay, does it cross that descending aorta? Is it truly a pericardial effusion, or is this a left-sided pleural effusion that is just very adjacent to the left ventricle? And so the initial image just has that fluid around the left ventricle, kind of looks like pleural effusion. Maybe we're dealing with a patient who's got a pneumonia or fluid overload. But when you do a rush, you should do 2 views of the heart. That's at the very least for the initial part of the rush. And so that second view is an apical 4. And you can see fluid is around the left ventricle, but it's also around the right ventricle. And so now you know, okay, we've now changed from a just regular hypotensive patient for in dialysis to a patient who might have an effusion. Now we can see the fluids across the midline. It is truly a pericardial effusion. But interestingly enough, this fluid is truly not around the atria. It's just around the left and right ventricle. So it's
Really interesting. Yeah.
And so that kind of threw them off, but pericardiocentesis was what was done. And eventually the patient went for definitive management and found that their dialysis catheter had been somehow advanced through the right ventricle. So caused this basically just tear in the myocardium, and the patient was bleeding out from their right ventricle, causing this effusion. And the reason it looked focal, I'm sure eventually it would make its way around the heart, but it's focal because it's just recently happened and it's starting to fill around the heart. And so this patient went from just a benign hypotension to full cardiothoracic surgery.
Wow. I was going to ask what happened, not the cath lab, full cardiothoracic surgery.
Yep. And that's the first case. I always present this case to the interns just to present the idea. But since then, I've been gathering some of my own cases. Next case was a 42-year-old woman. She was Spanish speaking and deaf. And although we have a great system in terms of having interpreters as well as iPads for deaf patients, but she came in saying she couldn't see in her left eye. And so in our triage system, can't see in the left eye. This is concerning for stroke code. And so the patient was sent to our blue box in the middle of the ER, so that way we can all run in and decide whether to continue the stroke code. The history, reading through this chart, it wasn't my patient, but it was here at this shop. Reading through the chart, the patient, there was clearly some question on the history. The patient, when they got back to the blue box, says, okay, it's not that I lost my vision, I'm having gray vision, sudden onset gray. Still the type of case that I love speaking to interns about, because do you want to keep the stroke code? Do you want to continue this train? And generally, most people, and even myself, I think, would probably continue this train. But the attending on the case did a POCUS ocular ultrasound on this patient. And if you look at these images, if you look through it, I think, most people, when I ask them, what are you expecting to see? They might say, okay, I see this is an ultrasound U-turn case, must be vitreous hemorrhage, maybe retinal detachment, something like that, and it's going to change management. But once again, this image I love to see is as we're fanning through the eye, you see the lens, and the lens is markedly thicker than any lens you've ever seen, you
Mhm.
typically see on ocular ultrasound. And so now you're left with this patient who the plan is stroke code, and you haven't necessarily come up with anything that's going to stop the stroke code because it's still concerning sudden onset vision change. But at least in the back of your mind, you're saying, there's something peripheral going on here. And I think this is, if you can look up a severe cataract case, that's what this was, is severe cataracts. And the thickness of the lens is just so jarring that eventually this patient eventually got transferred for ophthalmology. There was nothing emergent that needed to be done. But although we did the MRI and CT scan, they didn't get admitted for a stroke workup. We didn't continue with TNK or TPA when they came back from the scanner because we knew there was something peripheral, something in the eye, something structural happening, even though we didn't know exactly what that was when we performed the ultrasound.
Yeah, and I love that because arguably you averted patient harm, right? There was not unnecessary testing. We all know that TNK certainly can cause harm. So Focus made the diagnosis and prevented patient harm. I love it.
The other thing about this case is because if you present this to a group of attendings who want to learn ultrasound, they're like, what is that? What is that I see there? And I'm like, I can tell you it's a cataract because I know now. But in the moment, I don't think the person who was scanning, they were fellowship trained as well. I don't think they knew exactly what this was, but it still changed management without knowing exactly what the final diagnosis was. And I think
Mhm.
that's something that's like hard to communicate and and I think we all have the experience of it when we scan often, but hard to communicate that can happen and what to do in those situations.
Yeah. All right. You sent me so many good cases, and I think we're going to have to skip a couple of them because I'm dying to find out about this COVID positive patient. And again, I'm not going to leave the spoiler here, but tell me what happened with this case and how you ended up at this final diagnosis.
Oh my goodness. Yes. So I love when I get that 91-year-old patient whose only medical problem is chronic dementia. And you're like,
Mhm.
wow, you did a great job. You ate your Wheaties. Amazing. But we get this 91-year-old family says the past year has been they've noticed some dementia, but generally she takes care of herself. ADLs are great, but the past 3 days has had a cough and decompensating a little bit, not getting up and eating as much. And so just your typical kind of chronic dementia patient who this morning, family says she's short of breath. She's coughing. It's concerning. We're bringing her to the hospital.
Mhm.
She gets to us and she's hypoxic to 70s, pretty hypoxic, but some nasal cannula brings her right up. And otherwise, she's protecting her airway. Blood pressure is soft, hundreds over 50s. So we start some fluids and I'm bringing the ultrasound because I just want to see, okay, I'm dealing with a septic patient. What does her squeeze look like? Can I give the fluids that someone's going to be tapping my shoulder to make sure I'm giving? And so I'm bringing the ultrasound in, and as I'm scanning the heart, she's COVID positive. We're like, okay, we got a COVID positive patient. We get an X-ray, and she's got right-sided infiltrates. Looks questionable, but looks like pneumonia. So now I've got a chronic dementia patient who's had a cough for 3 days. They're COVID positive. They've got what looks like a right-sided pneumonia, maybe at worst aspiration pneumonia, given that it's right-sided. All I wanted to see was whether there was an effusion in the right base, and really generally just wanted to look at the bases to feel really confident about not putting too much fluid in somebody with poor squeeze. And in the right base, you could see what kind of looked like an effusion. Very clearly, you can see the diaphragm above this structure. Usually interns, when they look at this photo, they say, okay, that's an effusion in the base. And I'm like, look, here's the diaphragm. And if you follow the diaphragm and you see where it meets the spine, there's negative spine sign here. This patient does not have an effusion, but there is something here under the diaphragm that looks like an effusion. It was about 4 centimeters. When taking a second look at it, there was about a 4 centimeter tubular structure. There was part of the reason it looked like an effusion was because there were areas that looked like air, A-lines and gray shadow. And you could even see as the patient took a deep breath, the diaphragm would start to come down and this whole big structure under the diaphragm was preventing it from dropping. And what changed clinical management, there was no reason why I would get a C of the belly in this person. Pneumonia, maybe aspiration pneumonia. Why would I need to get the belly? They had no belly pain, no vomiting. But because I saw this structure, 4 centimeters, I'm concerned it could be dilated bowel. We add on the abdomen pelvis, and the patient has high-grade distal small bowel obstruction, marked gastric distension, fluid. The way the CT's read is that fluid kind of had backed up all the way into the esophagus. So she probably was an aspiration pneumonia, but because she had this SBO that was backing up all the way into her lung.
Wow, yeah. I don't think I would have made that diagnosis without ultrasound for sure, and I don't know that I would have caught that. That's such a great case.
Yeah, it was definitely one that, like, I ended up having to transfer the patient, so I was, like, very interested to see what happened, and She eventually passed, and they didn't do any surgery, but she was the NG tube and the decompression that happened after, she was much more comfortable. Before I transferred her, her respiratory mechanics had completely changed because in addition to the pneumonia was this huge small bowel obstruction.
So interesting. Now, you and I are both ultrasound aficionados, but I feel in the interests of fairness, we should probably talk about cases where maybe ultrasound wasn't as helpful. Can you tell me about one of your U-turn cases where maybe ultrasound wasn't as helpful?
So one of these cases is another patient who came in with, they had a history of chronic pericardial effusion, lung cancer, recurrent pneumonia, a lot of things in the chest. But they came in with right-sided chest pain. And on my exam, I got right-sided abdominal pain.
Mm.
And feeling like an astute clinician, I'm like, okay, let me see if I'm catching on U-turn cases. It's actually right-sided abdominal pain and not right-sided chest pain.
Mm.
And that ultrasound in there is about a 9 millimeter gallbladder wall, very thick gallbladder wall. And admittedly, when I look at these images, when I've seen that significant a cholecystitis, usually I know it's hard for me to put into words what fat stranding is. I don't know if you've ever tried to verbalize fat stranding on ultrasound. It's like
You know,
vague.
when you see it,
Yeah, you see it and you know it, but it's hard to put into words. And so this, I admit, like there was a very thick wall, but I saw no stone and I saw no fat stranding. And so it was just, but we scanned the chest and the patient had nothing really new. No, the pneumonia wasn't there. There was no change in the pericardial effusion or any PE. What I went with was that this patient might have cholecystitis, and they did get admitted. Our acute care trauma surgery team evaluated them. They got an MRI, and it ended up reading that there were these small cystic structures in the liver, and some of them had extended kind of adjacent to the gallbladder wall. And so what I was calling, and the official ultrasound or the comprehensive ultrasound also called the gallbladder wall as thick, but when they got the MRI, they said that is not part of the wall. That's just a cyst that's adjacent to the wall. And there were multiple cysts showing this image. I think most ultrasound trained people would say, okay, the wall is thick. It meets criteria. Meets criteria for cholecystitis, but that's not, but something looks strange about this. Something doesn't look right. And I still took the U-turn because it didn't have any other diagnosis. And the patient ended up not getting their gallbladder taken out, just had a kind of like a bronchitis type of picture at the end. And several day hospital stay, MRI and everything, when, made me wonder, okay, did I need to go down that right? Did I need to order that comprehensive ultrasound that funneled them down that path when, clearly their pathology otherwise was in the chest?
yeah, I think it's a good reminder that sometimes when we go look and we find things, and sometimes those things aren't necessarily related to the chief complaint, but I think that sounds like a pretty reasonable use of ultrasound, to be honest. I think I would have done the same thing. So I certainly don't want to end our case discussion on that note. I wanted to share my personal routine case, and then I'm going to ask you your favorite. So I was thinking about, I had a patient a little while ago who came in, she had a gastric bypass and she was complaining of epigastric pain. So of course, all of us were immediately down gastric bypass road. We're like,
Yep.
you're going to get your all contrast on the CT table. I've already called the surgeons.
Right.
And at some point in there, I thought I should look at her gallbladder because she still had her gallbladder, had not been taken out during the bypass. And I don't remember what made me think this. I think I was examining her and there was just something that, triggers in the back of your mind. I should go look. And I go look, and this woman has a raging cholecystitis. Thick wall, fluid, stones in there. Looking at her like, ma'am, we got to take a U-turn. We're going down an entirely different road right now. So I sent her over to radiology. Sure enough, she just had cholecystitis, unfortunately for her, a couple weeks after bypass surgery. So went back to the OR with a different surgical team. But I think about that because I think I would have gotten to the diagnosis eventually. We would have caught it on the CT, but it would have been a delay of at least a few hours. I would not have given her the right antibiotics. We got her to the OR a lot faster. So really just completely changed our direction of care and definitely, I think, improved her care. And so on that note, tell me about your favorite U-turn case.
Absolutely. Yeah, I think just piggybacking off you, the gallbladder is almost often a U-turn case because we were going down the CT road and ultrasound is much better for it. I've seen plenty of CTs that miss gallstones. But my favorite case is a patient who came in with right flank pain and just skipped through it pretty quickly. They had bilateral hydro. And it was strange to me that they had unilateral pain but bilateral hydro. So we got the CT scan and it was completely negative. They ended up calling them, when they wrote the kidney portion of the CAT scan, they said indeterminate mild hydronephrosis bilaterally versus bilateral peripelvic cysts. And this person had no other CAT scans. And I'm like, okay, most cysts are cortical. This person has a pelvic cyst, which looks like hydro, and they've got it bilaterally. That sounds strange. So I went back to the patient, did my renal ultrasound again. And this time, I think I may have either forgotten the bladder or didn't do a good bladder the first time. Second time when I go and I look, the prostate is huge, heterogeneous, and has some calcifications in it and is invading the bladder. And so that to me looks a little bit, I go back and I look at the CAT scan and it says prostate's completely normal. And so end up calling urology and they're like, okay, we can see him in clinic, no problem. But this guy has a BPH that's causing his mild hydro and he needs to get that prostate taken care of. And he was just somebody who I know, he knew something was wrong. He didn't feel normal. I'm not sure if he passed a stone or if he was just getting some sort of like intermittent, I'm not sure where his pain was coming from, but he was going to have that CAT scan that was going to say normal and he was going to go home.
Mhm.
He was going to move on with his life. But instead just saying, no, something's not right here. Let's look at the ultrasound. Okay, I can't tell what's going on with the prostate, but it's big. It's big and it's likely needs some sort of follow-up. He ended up getting treatment for his prostate cancer. And what I hope that prevents like the type of patient who would normally just go home, develop Mets. We'd say, why didn't we catch
We
this?
catch this earlier. Oh, what a great case. Like really using focus in a way to get that diagnosis. And yeah, that could have been a 6-month delay in care if that hadn't gotten caught in the emergency department. Hopefully, everyone listening to this is now completely on board with the idea of using focus to make these diagnoses. How would you say we could protocolize the use of ultrasound in a way that doesn't prevent it from aiding in the diagnosis on these dramatic cases?
I like asking this question to people, but I struggle to answer the question. Like usually quadrant pain, get the biliary. It's COPD versus CHF, get the echo. With that patient who was a stroke code, do you do an ocular ultrasound in every monocular vision loss? I don't think so. I think first step is to make sure that people don't anchor to the protocol so much that they don't think about ultrasound when it's not fitting a protocol. I think that's
Mhm.
the main thing that I try to communicate to residents. Like there's ultrasound protocols, but know that this tool can be used outside of that protocol. And I think maybe if there was some way to protocolize it, would say when there's a high level of diagnostic uncertainty in a patient with a high or low ESI or a pretty sick patient, then consider ultrasound. Once again, because there's a lot of subjectivity, and when I think about these cases, I can't say you ultrasound every monocular vision loss. I'd have to say like you can maybe protocolize the consideration. Consider ultrasound always in these patients with concerning vital signs and diagnostic uncertainty.
No, that makes sense. And I know something I've noticed kind of over the years in teaching people how to incorporate POCUS is we tend to think of this in terms of our diagnoses, right? I do a right upper quadrant scan if I think there's cholelithiasis. And I think sometimes approaching it instead in terms of the symptoms. They have abdominal pain. Okay, what could that be? I could consider right upper. They have dyspnea. Okay, I don't tamponad's maybe not on my differential, but dyspnea maybe should prompt me to do an echo, and sometimes I'll find tamponade. So how do we spread POCUS to the world to ensure that quality education is reaching all physicians and upholding this standard that does change a lot over time?
I was a scribe in the emergency department before med school, so I remember I've seen ultrasound be more prioritized, but I've also seen us struggle to educate. I think the education portions, even the attendings here who were excellent at ultrasound, it is a different skill set in order to take your unconscious processes and make them conscious so someone else knows what you're doing. And I think that creating novel case series, different ways to discuss ultrasound, different ways to express to other people why it's so valuable to us. I think a U-turn case series is also me expressing to other people why this is valuable to me. I'm like selling this to the rest of the team. Look how valuable this was to me. And so making that case we make a case in billing, we make a case in resident education. I think we should make a case in clinical management as often as possible. And I think that once again, just to go back to Dr. Gutman's talk, when he said some of the future is bringing this to other residencies, maybe having us have consulting roles so we can work on the teaching aspect of this, but also moving out into the other specialties like internal medicine, family
Mhm.
medicine. So now maybe there's a bit more of a system for it. And if my ultrasound at the bedside is understood by the family medicine doctor out there in the clinic, I imagine that process might work a little better, or we may use the ultrasound a little more because we're headed somewhere. We're communicating with someone else.
No, I agree.
Kind of the way I see it, but I'm really curious to what I'm trying to learn in my career also is how do we do this?
How do we do this and how do we work with our colleagues from other specialties? Because I know I'm always really fascinated by seeing, I work with a lot of family medicine physicians and they use a lot of POCUS, but they use it differently than I do. And it's been really fun talking to them about what's useful and not for them.
I remember in fellowship, I remember like coming to the family medicine clinic. What do you guys want to learn for ultrasound? I can teach you anything. What do you want to learn? And they're like, thyroid and liver. And I'm like,
I had a very similar experience. I was like, I can't do those, but I will go off and learn them and I will come back.
yes.
So Jordan, what do you want to leave people with that kind of as we conclude this episode?
I think I want to leave people with don't shy away from selling ultrasound with the concept of this is subjective in terms of whether this changed management. I think that I think step one is teaching teachers, teaching residents. Step two is convincing them to continue that education moving forward. I want to leave people with the fact that this U-turn cases has been a great way to sell that to the rest of the team. But there probably are other ways, other interesting case series that maybe we can share to further motivate the folks that are on the cusp, that are learning ultrasound, trying to get to where we're at, maybe not interested in a fellowship, but part of our ER team at large.
Thank you so much. I couldn't agree more. Thank you, everyone, for tuning in to this episode of Unmute Your Probe. Join us next month for a discussion on nerve blocks, what we should definitely use, what we should maybe not be using, and how regional anesthesia is being used in the emergency department. Thank you.
We hope you have enjoyed this podcast from the American Academy of Emergency Medicine. AAEM is a nonprofit professional association of over 8,000 emergency physicians dedicated to board certification and democratic group practice. For more information about AAEM, visit our website at www.aaem.org.